Your voice is not there.
Just give me a moment, sir. It's getting live. Sir, with all your permission, I'm starting this session.
Please.
Yeah. Good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, Professor Dr. Surendra Kumar Sharma, sir. Sir has done MBBS, MD in Medicine, DM in Endocrinology, and Professor of Endocrinology at Mahatma Gandhi Medical College, Jaipur. And today, sir is going to discuss on a topic, management of hypoglycemia with type 2 diabetes mellitus. By taking not much time to discuss about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you. Thank you. Good evening, dear friends. As we all know, diabetes is very common, and in our country, we are called the capital of diabetes. Okay, and that's why number of patients of diabetes are gradually increasing in large number. And today we are going to discuss what are the problems of management of diabetes. And one of the very important problem is development of hypoglycemia. So if the patient is not developing hypoglycemia, we can very well manage diabetic hyperglycemia. High sugar can be very well managed, but it is because of hypoglycemia. Sometimes our patients are afraid of hypo and they are not able to achieve tight glycemic control. So today's topic is hypoglycemia in our diabetic patients and how to manage it and how to prevent it. So what is this hypoglycemia? It is low plasma glucose causing neuroglycopenic and or neurogenic or autonomic symptoms which are relieved on raising the plasma glucose level by providing some glucose either by meal or by IV route. So it is low sugar level in general public sense we say, and it is divided into 3 levels. Level 1 and level 2 are mild. Level 1 means the blood glucose is between 54 and 70 milligram per deciliter. Level 2 means less than 54 milligram. The third level is very severe hypoglycemia. When it is developing, we require help of other person to overcome or to provide treatment. So it is requiring help from other person. So biochemical hypoglycemia is defined as blood glucose 70 milligram or below by ADA. Now, classification of hypoglycemia is also important, particularly in our diabetic patients. We say severe hypoglycemia when we require active assistance from other persons to treat it. It is independent of blood glucose, maybe very low, maybe moderately low, but it is the patient is not able to correct hypoglycemia by himself. Symptomatic means patient is having symptoms of hypoglycemia and he is having low glucose on glucometer. Asymptomatic means patient is, when you measure glucose, it is low, but patient do not have any symptoms. Pseudo hypoglycemia means that symptoms of hypoglycemia are there, but blood glucose is more than or above 70 milligram per deciliter. And probable symptomatic hypoglycemia means patient is typically having symptoms of hypoglycemia, but we are not able to measure glucose. That's why we say probably he developed hypoglycemia. So what is the pathophysiological parameter there? What we say that involvement of many counter-regulatory hormones and other organ system. Once the blood glucose goes down, the pancreas stops insulin secretion and there is an increased glucose secretion from the alpha cell. And this increased glucagon causes increased hepatic glucose output. On the other hand, low glucose causes stimulation of the brain. There is a sympathoadrenal outflow and pituitary gland is producing more growth hormone and ACTH, which act on adrenal cortex and causes increase in cortisol, which is again a counter-regulatory hormone, just like glucagon. And then, of course, this stimulation of ACTH will leads to adrenal medulla sympathetic stimulation, which leads to increase in epinephrine, which again is a counter-regulatory hormone. So all these counter-regulatory hormones acts on liver and kidney, and they cause increase in glucose production, either by breakdown of glycogen, which is deposited there, or because of gluconeogenesis, and glucose is corrected there. This is how things are happening in our normal person. But when you have physiological impact, when you look at physiological impact of hypoglycemia on different systems and their counter-regulatory responses, we found in the center we see hypoglycemia causes, you can say, stimulation of sympathoadrenal response, particularly in relationship to heart. There is a hemodynamic changes occurring, rhythm abnormalities are occurring, particularly QT prolongation. The eye problem is developing, diplopia, decreased renal sensitivity, retinal responses are reduced, loss of vision may be there. And in brain, neurocognitive dysfunction in the form of dementia, seizure, functional brain failure, brain injury, and cerebral ataxia. Other regulatory responses are also there in the form of inflammation. There is increased C-reactive protein, interleukins, and vascular endothelial growth factors are released. Endothelial dysfunction is there. Because of that, there is a decreased vasodilatation, and coagulation abnormalities are there. Because of that, there will be more chances of thrombosis. So dear friends, if you look at the consequences of hypoglycemia, you find that hypoglycemia leads to endothelial dysfunction. It leads to inflammation by release of these cytokines. It causes blood coagulation abnormality. And because of sympathoadrenal increased response and increased epinephrine, there are rhythm abnormalities and hemodynamic changes. These changes may persist to a tune of 48 hours. And sometimes even these effects are seen even up to 7 days after a prolonged severe hypoglycemia. So what is the impact of hypoglycemia on treatment adherence? So hypoglycemia significantly influences the incidence of patient's adherence to medication and glycemic control. Once the patient develops hypoglycemia, he is afraid of hypoglycemia. There is a fear of hypoglycemia, and because of that, he reduces the doses of his oral antidiabetic or insulin, and thereby leading on to development of uncontrolled hyperglycemia. And on the other hand, it affects the quality of life, and approximately 1 in 7 patients with diabetes misses their work once they develop hypoglycemia. So hypoglycemia goes undetected in uncontrolled type 2 diabetes. There is a 6-fold increase in death in patients with diabetes due to hypoglycemia. Hypoglycemia is a major barrier in achieving tight glycemic control in our type 2 diabetic patient. There is a significant number of patients with diabetes who are at risk of having hypoglycemic episodes daily because of either drugs like sulfonylurea or insulin, or they are having problem in taking meal or doing some extra activity. Recurrent hypoglycemia episodes result in unfavorable and serious clinical consequences, and considerable number of hypoglycemic episodes are asymptomatic. So sometimes patient is not realizing it, symptoms are not there, and many times they occur at night time and without much symptoms. Patient experiencing symptoms are prone to severe hypoglycemia, and which could be life-threatening and if not managed properly. So here we find that hypoglycemia effect on cardiovascular system. It causes sympathoadrenal activation, high hemodynamic effects, increase in ischemia and myocardial infarction, electrophysiological effects in the form of arrhythmias and prolongation of QT intervals. So here you can see hypoglycemia is causing prolongation of QT interval. Hypoglycemia is associated with significant prolongation of QT interval in our type 2 diabetic patients, and hypoglycemia is also associated with increase in systolic blood pressure. So here in a CGM study, whenever blood glucose is going down, that is by darker points here, the systolic blood pressure, that is the open circles, are going up. So hypoglycemia causes increase in systolic blood pressure. In other problems with hypoglycemia, there is morbidity of hypoglycemia and diabetes, brain, coma, seizure, cognitive dysfunction, and psychological effects are there. In musculoskeletal, there may be fall because of hypoglycemia, Patient may have accidents, fractures, dislocation, and it may cause driving mishaps. And of course, cardiovascular, as we discussed, myocardial ischemia, cardiac arrhythmias may be there. So in totality, we say, what are the consequences of hypoglycemia? In short term, acute symptoms, cognitive impairment, mood changes, work performance is deteriorating, patient is not able to drive safely. There are social activities which are impaired, like sports, travel, etc., and it may lead to morbidity. Long-term consequences are also there. Reduced quality of life of our patients, fear of hypoglycemia is always lingering on his brain. Weight gain is there because of subclinical hypoglycemia. Patient is eating in between, munching something or other, and employment and driving personal relationships are also worsen. Patient may not get good employment because of hypoglycemia. Worsening of diabetic and vascular complication may be there, and chronic syndromes are there. So consequences of hypoglycemia, we can see seizures and coma, accidents and employment problem, cardiac events, and hypoglycemic syndromes may be there. And you have fear of hypoglycemia, quality of life is impaired, and this prevents desirable glycemic target. So patient is having fear of hypoglycemia, he reduces on the treatment side and develop uncontrolled high glucose. So consequences of nighttime hypoglycemia is also there. During sleep, the sympathoadrenal response to hypoglycemia is blunted, and it attenuates the sympathoadrenal activity at night, leading to compensatory activation of parasympathetic system. These factors contribute to induce ventricular arrhythmias, bradycardia, ventricular ectopic beats, and the stress hormones that are secreted in response to hypoglycemia increases blood viscosity and promotes coagulation. It leads to endothelial dysfunction and the release of inflammatory cytokines in the circulation, recovery from which may take long time, even up to a period of 1 week. So there is circulatory level of inflammatory markers, vascular adhesion molecules are increased, and markers of thrombosis and platelet activities are increased. These lead to increased cardiovascular outcome in this patient. There is always a myth that probably hypoglycemia is occurring only in type 1 diabetic patients who are on insulin therapy. But we know that these are myths. Rarely experiencing hypoglycemia, it is again a myth. Patient with elevated aspiration may not develop a risk of hypoglycemia. Again, we see that it is wrong. Severe hypoglycemia due to the body counter-regulatory responses are not serious. No, it is serious, and no adverse consequences of hypoglycemia. We just discussed that it leads to significant adverse events. So myth of hypoglycemia is there. Though type 1 diabetic hypoglycemia is attributed to insulin and it is more common and more severe, but hypoglycemia in type 2 diabetes is also greater serious because of cardiovascular system abnormality. So detecting the cause of appropriate treatment is also required. So what is the cause of hypoglycemia? One has to understand it. So major issue to maintain good glycemic control, minimize the risk of hypoglycemia, and prevent long-term complication. So to look at the cause of hypoglycemia, one has to recognize the hypoglycemic risk factors. We have to monitor blood glucose, selection of appropriate regimens. Few drugs are more causing hypoglycemia, some drugs do not cause hypoglycemia, and education program for healthcare professionals as well as for the patient of diabetes. So what are the causes and risk factors for hypoglycemia? General causes of hypoglycemia are that patient is not taking his meal, he is avoiding or he is missing a meal, inadequate meal, delayed or missing a meal, or he is doing excess of exercise, too much insulin is given or oral anti-diabetic medications are given. Wrongly, he has taken twice rather than giving it once a day, and drugs and excessive alcohol consumptions are also lead on to development of hypoglycemia. Other risk factors for severe hypoglycemia are that advancing age, prolonged duration of insulin treatment. When patients want to go for tight glycemic control or strict glycemic control, the chances of hypoglycemia is higher in them. Impaired awareness of hypoglycemia is also there. There are few patients with long duration of diabetes, they do not appreciate the signs and symptoms of hypoglycemia. We label it as impaired awareness of hypoglycemia. sorry. During sleep also patient may develop hypoglycemia, and history of previous severe hypoglycemia is also there in this patient who develop severe hypoglycemia. And of course, very important, patients who are having significant renal impairment, renal failure, they develop more chances of developing hypoglycemia. So frequency of severe hypoglycemia both in type 1 and type 2 diabetes, you can see here, as the age is advancing, as the duration of diabetes is advancing, both in type 1 and type 2 diabetes, there is more chances of developing hypoglycemia. Hypoglycemic episodes often go unrecognized by patients. So hypoglycemia confirmed by CGMS is often unrecognized. So patient says that I do not realize that I have symptoms or signs of hypoglycemia, but when we put a CGM, it is recording blood glucose every 5 to 15 minutes for a period of few days to few weeks. Then you find that patient says no hypo, but 63% of type 1 diabetes are having blood glucose going below 70, and 47% of patients with type 2 diabetes are having chances of developing hypoglycemia. So 74% of all these events are occurring at night. That's why most of the time patient said, I do not appreciate hypoglycemia. That only be appreciated by continuous glucose monitoring system, CGMS. So hypoglycemic events which are occurring very frequently in our type 1 diabetic patients, but not uncommon, but slightly less than type 1 in type 2 diabetic patients. So causes of severe hypoglycemia in emergency unit, you find that in UK study, 28% of cases were hospitalized. 72% of these hypoglycemia patients are managed in ambulance or in emergency primary care services, and most episodes of hypoglycemia are treated effectively at home or at work by relatives or by colleagues, and they do not require emergency medical services. And clinical trials, most of the time when we are doing clinical trial with drugs, we usually exclude the patients who are having high risk of severe hypoglycemia. So increasing hypoglycemia when insulin is added to the therapy. So there are two drugs which are more commonly associated with hypoglycemia. Oral drug means sulfonylurea, and insulin, as we all know, insulin is an injectable drug which causes more chances of hypoglycemia. So both sulfonylurea and insulin are linked to severe and more chances of hypoglycemia. So prevalence of severe hypoglycemia in our type 2 diabetes increases with longer duration of insulin therapy. So if the patient is having long duration of insulin therapy, even when he is type 2 diabetes, he is having more chances of hypoglycemia. So what are the most common symptoms of hypoglycemia? Here you find that autonomic symptoms in the form of sweating, palpitation, shaking, and hunger. Neuroglycopenic symptoms where the brain is not able to get good glucose, and there is a confusion, drowsiness, odd behavior, speech difficulty, and incoordination. And general malaise is there, and you find that patient may complain of headache, nausea, etc. So some symptoms are behavioral and can be misunderstood by the patient and by their relatives also. So hypoglycemia adversely affect mood, cognition, and visual functions. So you find that there are abnormalities in mood, emotion, and motivation. Cognition is also impaired, and visual dysfunctions are impaired. But many times, patient and his relatives may not link it to development of hypoglycemia. So they should be educated that sometimes those adrenergic symptoms may not be there, but these behavioral changes may be there. You have to have a high index of suspicion that patient develops hypoglycemia. So symptoms of hypoglycemia, according to the individual pattern, individual factors, symptoms differ and are affected by multiple modifying factors. For example, they may be changing in old age. Sometimes old age patients are not able to appreciate the sympathetic symptoms of hypoglycemia, and they directly land up in cognitive dysfunction and behavioral dysfunction, or they may go into coma or a seizure. There are some drugs and alcohol may cause more chances of hypoglycemia. Differences in physiological responses. Some patients are appreciating it very effectively because there is a very brisk rise in glucagon, adrenaline, cortisol in them. Others may not have that brisk rise, and it all requires education and knowledge. So whenever we are treating our patients, we have to impart education, particularly when the patient is on insulin therapy or on sulfonylurea. And of course, we should understand that 75% chance are that they will be developing hypo during sleep. And whenever patient is getting up in the morning with the morning headache or sweating and very unpleasant, you can say, dreams, it is indirectly telling us that the patient developed nocturnal hypoglycemia. So symptoms vary within individual between hypoglycemic events also. So impaired awareness of hypoglycemia is also a very important problem. A diminished ability to perceive the onset of acute hypoglycemia. Clinical assessment should be based on subjective experience when the patient is awake, and syndrome may include reduced symptom intensity and number and altered symptoms profile and or failure to interpret symptoms of hypoglycemia. So many times we see with the long duration of diabetes, with advancing age, the patient is not able to appreciate the symptoms of hypoglycemia, and we label it as impaired awareness of hypoglycemia. It affects 20 to 25% of adults with type 1 diabetes and something like 10% of our type 2 diabetes patients on insulin. Risk of severe hypoglycemia is very high when the patient is not able to aware of symptoms of hypoglycemia. Spectrum of severity may be reversible when we will do some corrective measures, and no international consensus on definition of this impaired awareness of hypoglycemia is there. But mechanism behind the impairment of this awareness of hypoglycemia is that there is a vicious cycle of repeated hypoglycemia. So once the patient is developing hypoglycemia again and again, then the symptomatology of subsequent hypoglycemia is significantly reduced. So repeated episodes of hypoglycemia lead to less chances of appreciation of symptoms, definitive counter-regulatory, defective counter-regulatory impairment and awareness of hypoglycemia is there, and there is increased risk of and vulnerability to severe hypoglycemia in these patients who are not able to appreciate symptoms of hypoglycemia. Awareness of symptoms of hypoglycemia can be analyzed. Clinically, assessment can be done with a clinical history from the patient, history from the observers or relatives, and blood glucose monitoring data, looking at the frequency of asymptomatic biochemical hypoglycemia, and validated score systems are also there. So pathophysiology of impaired awareness of hypoglycemia is that there is altered regional blood flow, regional difference in blood brain activity, and evidence of cognitive impairment. So all these things may lead to a development of unawareness of hypoglycemia. So tools to capture hypoglycemia are firstly the history from patient or from observer or from relatives, and look at the diary of the patients for the record of blood glucose or CGMS data. Validated score systems are also there. Blood glucose monitoring data, evidence of frequent asymptomatic biochemical hypoglycemia is a you can say extrapolate from the blood glucose monitoring data, and correct hypoglycemia awareness screening. So here you find that screening for the risk of severe hypoglycemia, there are some risk factors. So simple questions may reveal risk of hypoglycemia. What are these risk factors? One is those patients who are having very tight control, where HbA1c is very low, and high pre-treatment HbA1c in type 2 diabetes. Long duration of diabetes, a history of previous hypoglycemia or recurrent hypoglycemia. Impaired awareness of hypoglycemia is again a risk factor for severe hypoglycemia. Recent episodes of severe hypoglycemia, daily insulin when it is very high, like 0.85 micro units per kilogram body weight, patient is taking more units than his weight, then chances of severe hypoglycemia is more. And patients who are physically active, like those who are involved in athletics, etc., or very strenuous games, they may have more chances of severe hypoglycemia. Various blood glucose monitoring tools are available for capturing hypoglycemia in the form of either recurrent or frequent self-monitoring of blood glucose with the help of a glucometer. Real-time continuous glucose monitoring systems are now available, and flash glucose monitoring systems are also there. So we can use any of these to identify, to document hypoglycemia. CGM, that is continuous glucose monitoring, gives more correct reporting of hypoglycemic events. So we can see here that overall and nighttime hypoglycemia retrospective study is telling us that it reveals up to 7 times more nighttime excursions that blood glucose meters are telling us in our type 1 diabetic patients. And flash glucose sensing technology reduces hypoglycemia in individuals with type 1 diabetes. So if patient is using these techniques, then the chances of developing severe hypoglycemia are significantly reduced. So in the last part of my talk, I will discuss what are the management line for the treatment of hypoglycemia. First important thing is patient education. Patient should be aware of what are the signs and symptoms of hypoglycemia, how to recognize it, and how to correct it. Diet and exercise relationship with sugar is also very important. Individualized HbA1c target. A old patient, we want to target HbA1c slightly less tighter. In a younger patient, because he can appreciate hypoglycemia, we want to go for a tighter control. Improve pharmacological treatment. So if the patient is having good control and patient is not developing frequent hypo or hypers, then he is having less chances of developing hypoglycemia. And of course, glucose and medication monitoring is required. And there are now technologies in the form of glucometer reading and CGMS, etc. So educate patient and caregivers on how to recognize and treat hypoglycemia. That is the most important part in our scenario. Strategies to prevent recurrent hypoglycemia, discuss hypoglycemia risk factors and treatment with patients on insulin or particularly on those on sulfonylurea and glenides. Instruct patient to report hypoglycemic episodes to their doctor or educator, and consider enrolling patients with frequent hypoglycemia in a blood glucose awareness training program. So here is a UK Daphne audit system where they looked into, this is a structured education program, and in Daphne is a 5 days course for adult with type 1 diabetes that focuses on adjustment of insulin according to the carbohydrate intake and reflective use of home blood glucose monitoring. So education is very, very important. So what are the strategies to prevent hypoglycemia? Diet and exercise is most important. Follow a predictable eating plan. Consider carbohydrate counting. Monitor glucose before and after exercise. Eat pre-exercise snacks if blood glucose levels are low or declining. Modify physical activity that has led to hypoglycemia, and adjusting insulin in relationship to exercise. And of course, very important, avoid alcohol. Medication, we have to look into what the medications patient is taking, and sometimes we have to change the medication. Like sulfonylurea glenides are causing more hypo, insulin is causing more hypo. Now we have many good drugs available which are improving glucose profile but have very less chances of developing hypoglycemia. So consider if the patient is on the right medication. If add-on to basal insulin is needed, consider alternative to prandial insulin. If on basal bolus insulin, check blood glucose before each meal every day, ensure correct doses, and consider insulin adjustments. And sometimes we have to change the insulin from human regular insulin to analog insulin, or from NPH insulin to long-acting basal insulin, which are newer basal insulin. So technological strategies for reducing risk of hypoglycemia are also there. Better insulin delivery in the form of automated bolus calculators and insulin pumps are available. Better warning system in the form of continuous glucose monitoring, flash glucose meters are monitoring systems are available. Better prediction blood glucose awareness training and pattern of diagnostic CGM, and automated insulin delivery system where the insulin pump is telling you that glucose is going down because of closed loop systems are available there. Now comes how to manage acute hypoglycemia. If the patient is conscious, then treatment is in the form of immediately take 15 to 20 gram of fast-acting carbohydrate, like small glass of sugary drink, 3 tablets of glucose, or 5 sweets or small carton of pure fruit juice. Or if the patient can take glucose gels also, which are available now. Some people may then need a snack. Following this acute, you can say, intake of fast-acting carbohydrate, they may take slow-acting carbohydrate following this acute release of carbohydrate, so that patient will not have recurrent hypoglycemia. If the patient is unconscious, then we have to be, patient should be put into a recovery position in the lying down, face is turned to one side, and give glucagon injection and call an ambulance. And if the facilities are available, we can give a glucose IV drip. So tackling the problematic scenario of hypoglycemia, what are the steps in preventing hypoglycemia? First is acknowledgement. That is acknowledgement of the risk of hypoglycemia in our type 2 diabetic patients. It is there. Avoidance of excessive glucose fluctuation. Then consider the therapies with low risk of hypoglycemia, aiming to create stable glucose in a range of decreasing complications and reducing variability of glucose profile, and discussing and treating these patients, reviewing the CGM data or flash glucose monitoring system reports with the patient, allow for the open discussion about the incidence, timing, and causes of hypoglycemia. So there are some change in our glucose treatment profile also, treatment profile of diabetes, in the form that we may change the oral drugs which do not cause hypoglycemia, like DPP-4 inhibitors, SGLT2 inhibitors, pioglitazone, etc. Or sometimes we change insulin from regular insulin to analog insulin, and NPH insulin to long-acting insulin, basal insulin in the form of glargine or degludec, etc. So general recommendation on hypoglycemic management is patient treated with sulfonylurea, glinides or insulin should be educated about hypoglycemia, treat self-monitoring of plasma glucose levels once it is going below 70, and regularly be asked about the glucose level and what are the symptoms of patients. And when hypoglycemia become a problem, healthcare providers should consider risk factors, avoid sulfonylurea if possible, use insulin analogs, seek to achieve the lowest HbA1c level that does not cause severe hypoglycemia. So there is always a caveat: treat very intensively but avoid hypoglycemia. So rule of 15 is there. First is have per patient eat or drink active rapidly acting carbohydrate 15 gram, and may follow it again and recheck blood glucose after 15 minutes and repeat the treatment 15 gram of glucose if glucose is still low, and if symptoms continue, blood glucose level do not increase, call a parent or guardians of the patient. So dear friends, we have discussed definition of hypoglycemia like less than 70, level 1, less than 54, level 2, and severe hypoglycemia where you have to give support to the patient. Also, this is a problem which is there not only in type 1 but type 2 diabetes patients also. Symptoms are age specific and changes during the treatment and duration of diabetes. Hypoglycemia and cognitive defects are there, and neuronal death in hypoglycemic doses is leading on to coma. Hypoglycemia affects subsequent renal function. Severe hypoglycemia seen more in type 2 diabetes patients, and there is a impaired awareness of hypoglycemia, which is a serious issue. Try to access for impaired awareness of hypoglycemia in the form of giving them education. Technology use is also there, and rule of 15, what we discussed in the last, is there for the treatment of these hypoglycemic patients. And whenever we are able to give glucose in an unconscious patient, give glucose 25 to 50% glucose, 25 to 50 ml IV. So if that facility is available. Okay, so I stop here. If you have any question, I can take it. Thank you very much.
Yes, sir. Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one. I definitely think this session knowledge is going to help all the participants who have joined this session. As I can see, sir, we have received some question from the participant end. If you allow, can I take this question with all your permission?
Please.
Yeah, the question is, why is rapid diagnosis and treatment of hypoglycemia necessary?
If hypoglycemia is not corrected rapidly, then brain requires glucose for its metabolism. All other organs can utilize protein, fat, ketones, etc. But it is the brain which requires for its survival glucose. So if hypoglycemia is prolonged, there is a permanent neuronal damage which may occur. Sometimes patients land up in severe coma, and we find that that they are not revived from that coma in hours and days, and sometimes it is a permanent. And there is a term called death in bed because of severe hypoglycemia during the night time. Many of these type 1 diabetic patients died during night because they were not able to appreciate symptoms of hypoglycemia while they were sleeping. And this hypoglycemia is very severe, and it leads to, as we discussed, cardiovascular problem, arrhythmias, and patient died in the bed. So that's why rapid identification and rapid treatment of hypoglycemia is required. Thank you.
Yeah, thank you so much answering it. I hope that participant have received his answer. Moving forward, another question is, why is the timing of onset of symptoms relative to meal indigestion significant in evolution of hypoglycemia?
Well, if the patient is having indigestion, or for example, he's having nausea, vomiting, diarrhea, etc., then whether he has taken meal, but still that meal is not providing carbohydrate because of this GI problem. So patient, when take regular drugs, either sulfonylurea or insulin, and he is not having, you can say, good appetite because of these problems, then he may end up in hypoglycemia. So we have to be very careful that if the patient is having all these GI problems, we have to reduce the doses, and we have to make sure that patient takes something orally, or if not possible, then IV glucose drips are to be given to these patients. Thank you.
Yeah, thank you so much once again for explaining it really well. I can see there is couple of more questions. We will be taking
Please.
last 2 questions for today's session. And the question is, how does obesity affect the risks of developing type 2 diabetes mellitus?
Well, it is not directly linked to our topic, but I can tell you that when a patient develops obesity, there is development of high insulin resistance. And if the patient is having a strong family history of diabetes, or he is having, you can say, advancing age, then chances are that he may develop again diabetes because of insulin resistance. So obesity is one of the very important cause of development of type 2 diabetes in our patients. Thank you.
Thank you so much once again, and we'll be taking last question for today's session. And the question is, how does insulin resistance affect glucose tolerance in type 2 diabetes mellitus?
Well, insulin resistance is, we say that once the patient is having insulin on board, but it is not effective. What it means that in the peripheral tissue, like muscles, adipose tissue, liver, and many other organs, you require insulin for the uptake of glucose. So if the insulin resistance is there, then this uptake of glucose is significantly reduced in these areas like muscles, etc. So patient utilization of glucose is decreased, and patient blood glucose goes up, and we say that you develop diabetes. Thank you.
Yeah, thank you so much for answering all the questions. As I can see, there is no more question from the participant end. With all your permission, shall we conclude this session?
Okay. Good night.
Thank you so much once again, and take care of yourself, and hope to see you again with different topics. Sir.
Absolutely.
Thank you.
Thank you.
Yeah.